Our first panel today is focused on hospital operations and response. Joining us, we have Dr. Lane Donnelly, our Chief Quality Officer here at Stanford Children's Health, Professor and Associate Dean at Stanford University School of Medicine. We have Ms. Alison Kerr, the Chief Administrative Officer of Clinical Operations at Stanford Healthcare. And once again, we have Dr. Mickey Halberthal, the Director General and CEO of Rambam Healthcare Campus.
Morning, everybody. My name is Lane Donnelly. Thanks for having me here. I think I'm going to go first, and then Allie will go after me. I do have some slides. I'm going to talk about the social and technical domains of execution during the COVID-19 pandemic. And this is a little bit of the background of how we think about our approach to COVID. And Allie is going to talk about some more of the details. So a little bit of background to that. If you think about the debates around how to optimally execute on tasks, there's often a debate between which is the more important thing to focus on, your processes or your culture. And I'd like to talk about two different people's opinions at either end of that spectrum. So this is John Shook. He was the first American to be an employee of Toyota in Japan, and he was also responsible for introducing the Toyota production system at NUMMI, which was the joint venture between Toyota and GM that was in Fremont, California during the 1980s. He's written many great books like Managing to Learn and is considered a lean expert. And obviously, he's a process guy, so he would argue that where you need to start is to focus on your processes. You can build in your leaders' expectations into those processes and therefore change your culture. At the other end of the spectrum, this is Edgar Schein. He is an MIT professor emeritus. Many people consider him sort of the father of organizational development. He had a sociology background. And obviously, he comes from the social side of things. And he would argue that you need to start by making sure you have the right culture, that regardless of what your processes are, if you don't have a culture that allows people to interact in the right way, you're not going to do well. Both Ed and John are on one of our advisory boards, and through that, there's been a debate between the two of them on how do you come up with the optimal way to view this. And that has led to looking at healthcare execution from both a technical domain and a social domain. The technical domain being the task processes or how the work is being done, and the social domain, how those doing the work interact, and also how well they are doing. And that optimal execution will really occur if you have deliberate consideration of both. Now, normally when we think about this, we think about these things during a normal, stable period. You remember normal times where people weren't wearing masks, going to concerts and things like that. And in healthcare, if you think of normal times as thinking of how do you execute on improving a process such as CLABSI reduction, you think about the technical aspects of things, the standard work and things along those lines, and the social aspects, how do you drive accountability and things along those lines. The question is, do those concepts really also pertain to when you're managing during a chronic pandemic? And I would argue they probably are even more important during that period of time, that during healthcare delivery, during managing a chronic disaster, you have to pay particular attention both to the technical and social domains. And if you organize the things that have had to occur during this pandemic, you can think of them in those two domains. There are many things that our work and how we do the work has dramatically had to change. Some of those things, how we govern how we secure supplies, personal protective equipment, that our occupational health is changed to handle a pandemic, how we test, surge planning, financial windfall planning, reactivation of elective procedures after they were stopped, digital ambulatory visits, our visitation policies, et cetera, and many other things. On the social side, making sure that the incredible stress that our workforce has been under is helped and abated. So lots of communications, town halls, leadership rounding, making sure that our workers have everything they need, like child support, work flexibility, meals and shelters when necessary, that we have plans for caring for for providers when they do become COVID positive in those rare events, and many things to drive teamwork. So that is really the framework in which we've come to think of the tasks that have to occur to respond to COVID-19. And with that, I will stop sharing and turn it over to Allie.
Okay, great. Thank you much, Lane. So I'm going to talk about how we responded at Stanford Healthcare to the current crisis. I'm the Chief Administrative Officer for Clinical Operations at Stanford, and part of my portfolio is the Office of Emergency Management. And one of the things, reflecting on Lane's presentation, is talking about processes and systems and functions. And from an emergency management perspective, it was important to remember that we had processes and functions. We did have emerging infectious disease plans. And so that was our starting point for addressing this global pandemic. So going back to the plans that we have, and then we very quickly stood up our incident command system using the HICS structure. We're uniquely positioned here at Stanford in that we actually have 3 acute inpatient hospitals. So we have the Children's Hospital, the main Stanford Adult Hospital, and then a community hospital that we own, the Stanford Healthcare Valley Care across the East Bay, and then a number of clinics into medical foundations. But like any HICS structure, we organized our response around operations, logistics, planning, and then obviously the financial implications. And I'll walk through these briefly in terms of some of our action plans. This is our high-level timeline of the event, and obviously we are still in the event. But important to note that January 8th, we were routinely meeting in terms of our emerging infectious disease work group, which included our epidemiologist. They were already looking at what was happening in Japan and in Asia. Further complicated, we had what we call a gown activation, and this doesn't seem much by itself, but early mid-January, all of our surgical trays were recalled sort of nationally, and we had to actually stand up our command center. So we had some early planning in terms of getting ready for large-scale events. We developed, in addition to our command center structure, there was 2 groups mediated by what we call our CORT, our Clinical Operations Resource Team, which is our executive oversight, led by myself and 2 of our chief medical officers. And then we had our PORT, our Procedural Operations Team, which really did a lot of the boots on the ground. That was led by Dr. Mary Hahn and Dr. Sam Wald, the day-to-day operations of keeping our employees safe and the ever-changing rules and policies around the ever-changing information. So this is just a very high-level timeline of where we are, when we took our surgical cases down, etc. Now I just want to go into some of the logistics and planning activities. So in terms of the logistics underneath our HICS and our CORT structure, within 24 hours, we had set up our ED drive-through for testing. We had reactivated 2 different units very quickly. We had our points of entry developed as well as our screening plans. We had looked at all of the ventilation in our building, and we were fortunate in being in a brand new hospital. So our new Stanford Healthcare Hospital opens January 16th, which had probably the sort of highest level work airflows. And so we were able to change each of our private rooms, their airflows very quickly, which was incredibly helpful to help create capacity in terms of HEPA filtration. And then we also obviously looked at our workforce. We have a labor force through our HICS structure that we activated very quickly. So many other logistics other than that, but sort of within the first 24 hours. And from our planning team, we had a plan for 900 plus patients. We were told by the county to prepare for about 200 ICU patients, which we were ready to do. We had flow plans for that as well as a resource plan. We developed our physician teams, our nursing teams. We assessed our ventilators, dialysis, ECMO, all of our medical equipment, of course. And we had the good fortune of having both our new hospital as well as our older hospital, which was still in play. And then from a data perspective, we had very good line of sight. While not necessarily the first day, we developed dashboards around all of our PUIs, our assets. So you can see the number of ventilators and ECMO. And this was a real-time dashboard where we could follow not only our COVID numbers, both within our hospital and our health system, but also within the county. And, our teams met at least once a day, if not twice a day, and having information flow up through the HIC structure. In terms of our operations teams, obviously workflows around transfer center, education, workflows within the hospitals, OR and urgent intubation, and standardization across Stanford Medicine, as well as staffing plans. We were fortunate enough never actually to receive a surge of patients, but I would say the organization was certainly ready. Just to remind folks that this is the flow of resources within a HIC structure. So the FEMA response is down here all the way up to Stanford Healthcare. So we first go to our county and then to the state and to the feds. What's important with this is we put through a number of requests, and we, at the end of the day, looking back, received only about 23% of all of our requests that we had. That would be for PPE or equipment or supplies. And so right from the get-go, we were very creative. Our supply chain was incredibly creative in understanding that as most hospitals, we were going to be on our own and we needed to help to manage our own supply chain. One of the other unique things that Stanford Healthcare did is that, led by Dr. Ben Pinsky and Dr. Scott Boyd, the Stanford Clinical Virology Lab was one of the first academic medical centers to develop and obtain a diagnostic COVID-19 virus. That we launched that March 4th. And for a period of about 6 weeks, we were doing all of the inpatient COVID testing and outpatient for hospitals in Northern California. And we've had a very liberal policy of testing our employees and anyone that should ask. As well, Dr. Scott Boyd has led in the serology testing, in advancing that serology test pending FDA approval. That was launched on April 10th as well. We've done north of 300,000 RT-PCR tests. And we now are pooling in pools of 4. We have applied for pooling of 8, and we continue to serve many, many hospitals at this point in time. So one of those uniquely Stanford things that we were running to catch up do much testing as we could as well to support the community. There was also many uniquely Stanford drug-related trials. So this just talks about the over 20 drug-related trials supported at SHC, including the FDA first remdesivir trial, monoclonal antibodies and combination treatments, and now part of prevention vaccines now starting and participating in 2 of those vaccine trials. And then now as we think about a pandemic response, right? So we are still in the middle of it as this pandemic goes from acute to what I would say is chronic. We continue to need to keep our minds on preparedness and response. We are not in the recovery phase now. We continue to watch both county, regional, and national data. We are in what I would say a stable phase right now, but our county numbers continue to go up as well as our California numbers. We were uniquely challenged with a number of additional, what I would say, disasters potentially. The bottom right picture is actually a real picture of SHC during the summer. We had an extensive fire season. The smoke, the air quality was incredibly poor up to levels of hazardness. And the toll on our healthcare workers and the mental health of the community was certainly challenged, as well as recent cybersecurity challenge. So the concept of concurrent disasters we certainly pay attention to. We continue to prepare for flu season, the vaccine planning, and are now working to support the schools and community opening. Just in terms of key lessons learned, incident command structure is challenging within a matrixed environment with lots of entities. We had a broken and unreliable supply chain. That would be no surprise to anybody. And the incomplete and ever-changing information related to this novel virus. The things that worked well and we were very proud of and continue to be is that we're uniquely prepared to serve the community, specifically with testing. We were able to surge very quickly. Our operational nimbleness and caring for our teams, we kept our healthcare providers safe, and we continue to offer testing for everybody and some of the psychosocial benefits we provided to our staff as well. So lots of information to go through, and I'm happy to pass it off to Meredith to our next speaker, please.
Thank you. So we're excited to hear from you, Dr. Halberthal.
So hi all once again. I will tell you a little bit about how we coped with the COVID here at Rambam. During those last 7-8 months. First, a few words for you that are not familiar with the Rambam Healthcare Campus. This is the campus. As you see, we are next to the sea, and this is a huge benefit. We are academic medical center affiliated with the Technion. The medical faculty is here on our left. We are the only tertiary care center in the northern part of Israel. So we are giving response to 2.3 million people, about 12 district hospitals. And we have 1,100 beds and 5,300 employees. So this is what happened in Israel with the COVID. And if you take this graph, it looks like a roller coaster, and this is where Israel is at, because basically it is a roller coaster. While in the beginning, in March, April, and May, we had the beginning of the COVID, and it really subsided really quickly with the lockdown, and the government thought that we won COVID, and went back, opened the lockdown really quickly, and the immediate effect of that we had an immediate rise in the amount of patients in the summer. There was again an attempt to do something about it, but it was a failure. And then in September and October, we had a major rise in the amount of patients. So altogether, about 320,000 were infected. And as said before, mortality of 2,600. And it's right, the mortality rate is about 0.8%. But still, the burden on the medical system was immense, because one needs to understand that we spend only 7.4% of the GDP on healthcare, and 1.74 beds per 1,000 citizens, and we have issues of manpower. And this is what happened at Rambam in Israel, and you see that the first wave and the second wave, maybe this continues, and the third wave, that we reached over 10,000 new patients a day, and it was about 15% confirmed cases a day out of the total tests that were sent. And obviously there was no way to handle a situation like this, and this was especially affecting the northern part of Israel, and the only solution was a lockdown, and you can see again the effect of the lockdown. And unfortunately, now that they are again opening for basically the third time the services, we see again a rise in the amount of patients in the hospital. Again, like you, we have our own dashboard. You can see the amount of patients that we had throughout the time at Rambam. This is from last week, and during this weekend, we already see a deflection in the curve, and that we start accumulating patients. We can see in our dashboard. The amount of patients that we have, and the acuity of the patient, how many ventilated, what's happening in the positive COVID emergency room, and very important also the amount of staff that we have in isolation. At one point of time during the event in the summer, we have 5,300 staff in the hospital, and 180 staff members were in isolation. And obviously, when we have to deal again with continuous medical care in the hospital, open solution for COVID patient, and at the same time have basically 4 or 5 wards at home in isolation, that created a huge challenge on the system. So this is our opening situation in very low expenditure on healthcare, very low bed counts with average occupancy around 100%, issues of manpower in all sectors, basically a starved system. But we were lucky that during the beginning, we were managed to hold the amount of patients and basically flatten the curve. And by that, having the opportunity to get some of the equipment in the beginning, in February, we have only 110 excess of ventilators all around Israel. Most of them were not working because they were not maintained. So this was a major issue, and obviously that changed. Whenever there is issues, always there is inspiring things, and no doubt the inspiring things around what, to my mind at least, is first the commitment of 5,300 workers at Rambam. But we can talk about all the medical staff around Israel, really devoted. And if you obviously can understand the devotion of people that looking after patients, physicians, nurses, allied professionals, but we're talking about all the engineers and the cleaning people and all the rest that really did a lot of work. Lots of connection with the industries. We came with unmet needs to the industry, not medical industry. Most of them were military solution industry, and they gave us huge solution. I will talk about this tomorrow to help us run the situation. Lots of help from the partners around the world that supported us, and really inspiring thing that you'll hear a lecture about it is the joining of the IDF Medical Corps and to us, and working together shoulder to shoulder with the medical staff running a unit for COVID, which is really different in many other ways. So we went to phases. The first phase that we had was, just we needed to open negative pressure isolation room, but obviously this was not enough. So we were asked to open COVID departments. And what we have done, we located one of our buildings that is isolated and has the capability of isolation, all the ventilation and air conditioning. And we within days, we made negative pressure rooms and a solution that initially for 30 patients, 6 ICU, but immediately it was not enough. And you can see some clips of how it looked like. And in the third phase, we were asked to add another 66 patients. And altogether, we had in this part of the hospital around 80 patients and around 25 patients with ICU. Once we saw the amount of exposure that we have around us, we understood that we need to have a solution for a bigger possibilities. So we used our solution, the SAMI Ofer Fortified Underground Emergency Hospital. You can see a clip of the hospital over here. This is a solution we created at the end of the 2006 war in the north part of Israel. None of the hospital was fortified, and we took two solutions, or two issues that we had. One is the fortification, the other is parking lot, and we made a versatile parking lot for 1,500 cars that in case of an emergency transforms to the biggest underground hospital in the world, totally fortified for 2,000 beds. We were asked by the Minister of Health to supply solution for 760 patients, 170 of them are ventilated. When we talk about the different solutions that we gave, when we talk about the initial solution of department, the lead medical care was per patient. This was like ordinary ward. The idea is to get the best practice to each and every patient, using remote medical care, having isolation of air conditioning and ventilation and access. And basically, the idea was, in order to protect our staff, to create physical distancing to the patients with using all kinds of monitoring system from far. And this was modular depending on the acuity of the patient and the number of the patient. When we're coming into opening the Sami Ofer Underground Hospital, one needs to understand the size of the place. It's about, each floor is 5 acres, 3 floors of 5 acres. And the issue becomes, the main issue becomes mostly logistic and command and control, and to use our resources more efficient in order to save as many people as we want. So using the semi-offer underground hospital was a big challenging, and I talked about the size of the place. Initially, the place was planned in order to give solution for conventional warfare, non-conventional warfare, meaning chemical warfare, when the compound itself is supposed to be totally decontaminated, clean, while the outside is contaminated. And obviously now with the COVID, it was exactly the opposite. And you see the big chimneys that we had to build in order to exhaust the ventilation outside. By the way, now that we've made lots of exams, there was no viruses exhausted outside. The other thing, we needed to create more intensive care beds, and this was a major issue. Obviously, when we use the underground hospital, before the first patient goes in, we had to get everything prepared. So it was the New Year in Israel. On Monday after that, we have decided to open the underground hospital. And by the same week, Thursday, 2 o'clock, we had the first patient. It's a huge open space, so there's no privacy, issues of noise, and I will talk about communication tomorrow, issues of staff recognition, light around the clock, and places to dress and undress along. This is you can really understand the size or the magnitude of the place. 5 acres each floor. This is 4 operating rooms inside, all the intensive care beds over here, and all the actual rewards, and the new emergency room for positive COVID patients in case a patient like this arrives. You can see some pictures out of the CTVs. How does it look like? This is basically one of the officers from the army treating a patient. You can see all the equipment around. It's really crowded, but basically it's not a parking lot that becomes a hospital, but it's a real hospital with all its capabilities. We were lucky, and we'll have a discussion later on, because once we opened the underground hospital, the solution of infrastructure and equipment, we had a solution, and we were left with a basic major solution of manpower. And we received a major help from the Israeli Defense Force, the medical corps that come to our aid. And this is the opening of the medical corps with the Ministry of Defense and Ministry of Health, and this was the opening of the Ministry of the therapies by the Brotherhood, the IDF Medical Corps. And they already treated 60 patients over there, though this is not the common thing that they are doing. So this is what happened with us during those 8 months. Unfortunately, we see that there is again rise in the amount of patients. So we are just waiting to see what will happen next. And we continue to work in the underground hospital, and at the same time continuing to work with regular patients in the above the ground hospital. Thank you.
Thank you to all of our speakers. I think perhaps we have time for maybe one quick question. So I want to open it up to the group and think about maybe perhaps the top 1 or top 2 lessons or themes that you think could translate to other systems that are not as well resourced as our Stanford and Rambam campuses.
I think that one thing that we need to understand when we deal with COVID is first to be humble. We know nothing. And I think that this is very important. It really transforms and changes, and we have to be really flexible in the way of thinking and the solution that we are giving. You know, we cannot, be building a plan and stick to a plan. We had to change all the time. And if you look you know, a few months ago where we were at and where we are now is really different. And I think that the way is to look at it, how you're using your resources the most efficiently, and this depends on the amount of resources that you have, obviously.
So Mickey took my two words, honesty, but I would add communication to that. So I think that when you remain humble and you don't know everything and things are changing, that it requires us to be completely transparent with our data, with the information we know and that we don't know, and that we continue to over communicate in these times of anxiety to make sure we have the trust and confidence of our teams. And so from a leadership perspective, I think transparency of data and communication to our staff is important.
I think those are the important things. I don't really have anything to add.
I think that's going to serve as the perfect segue to our next talk. Before that, we're going to take a very short break, a very lean 10 minutes, and then hopefully we'll have you back here to join us for our next session.